in the cannabis plant, it's one molecule amongst many. And so we know when we just talk about CBD, it's a little bit, it may not be accurate depending on what you're working with. And let's look at that, because what I try to teach my patients and teach other practitioners is you got to understand what's actually in the oils. Like, what are we actually offering to people, or what's potentially available to people? And that's a good question. So let's look. Well, the oils typically, if they are derived in this fashion, come from plants. You grow a plant and the plant has specific properties to it. You extract that out and you create an oil. The oil can have various composition, and that composition is usually some degree of CBD, represented by the green here, some degree of THC, represented by the gold, and then a smattering of all those other things that I showed you in that flow chart. All right, well, when we extract these, we can make two real, predominantly different types of oils. On one hand, we can make a purified cannabinoid oil. We can focus on one of the cannabinoids. So it's 99% pure of that and 1% of that rainbow color up there, which is everything else. What products are those? Those are things like Epidiolex, which I think some people in the UK may be familiar with. Charlotte's Web, well, if you're in the medical cannabis space or cannabis world or have done any reading about it, that's something that you probably have come across. And Cordylex, which is one in Canada that's available. So these aren't common, they're quite rare, whereas the other types of preparations are a lot more common. And these are preparations that have variation in their composition, as you can kind of see there. So we can have a type 3 oil, which is a CBD dominant oil, mainly CBD, but still has some THC and the other stuff. And those examples are things like 1 to 20s, 1 to 25s, where the convention is THC first, CBD second. You can have a balanced oil, like a type 2. There's some examples there. You can have a type 1, a THC dominant oil, which has the ratio reversed because the THC is first. So you can have a variety of these, and these are called cannabinoid rich extracts. All of these come from plants. They just vary in their composition. And in Canada, we mainly have these types of oils. We have the one on the other side, as I showed you. So that's really important to understand. And some names that we see in the literature and all over the place, these are a smattering of names. They're so confusing. I never use them. I use purified cannabinoid rich extract because it's more descriptive. It makes a lot more sense. Hemp, that's important. What is hemp? Hemp is just a variety of cannabis that has less than 0.3% THC. Therefore, when you make an oil out of it, you get a purified cannabinoid oil, and that's what Charlotte's Web is. Okay, so that always comes up. So that's just to clarify that. Okay, that sets the stage. It's important to set that stage because in order to understand the evidence in epilepsy, you got to know what the oils are. So when we look at these two different types of oils, we see that the main, most predominant, best evidence in epilepsy comes from the RCTs, the randomized control trials, of which there's 5, and that's the CBD pure, so the purified CBDs. We don't have any in these rich extracts, and this is where a lot of the current discussion is in the academic space and in the medical cannabis space, is which one of these is better and which one can we use and which one can we potentially use in our patients. If you look at the different trials, here they are. So you can see most of these, all the RCTs have been done and purified with none in the CBD rich extracts. So if we look at the evidence from these RCTs, because this is the highest level of evidence, let's take a look and see what it shows. Well, here are the five trials broken down. So you can see the age ranges here, right? Mainly pediatric, but there's still a lot of adults. If we go to the total, we come across here. So the number of patients total have been 774 patients have been put through these really high level, expensive, best quality evidence trials, with the majority pediatric, but you still have a significant number of adults. So we often say there's no adult data, but that to me is pretty much some adult data right there that is hard to ignore. Now, this part here is showing the CBD amount. Remember, this is purified CBD, so there's very little to no THC. These were the Epidiolex trials, so it's mainly CBD. And this shows the amount of milligrams of CBD per kilogram per day. And as we look down here, we see there's 5, 10, 20, 25. We go across here, you see the totals, and you can see that most of the data has been worked on in the CBD 10 and CBD 20. That's where we get most of our data. Why? Because when we did the studies, it showed that most response occurs in that range. When you go higher than that, you kind of get a lot of side effects and not really improve seizure control. Lower than that, you don't get enough seizure control. So we know a dose range for CBD, like there it is. That's pretty good signal right there, and kind of the best signal that we have right now in any kind of cannabis trials in any condition when it comes to dosing. And if we go across the outcomes of these trials, mainly, if we summarize this stuff, we can see they were mainly done in children, they were mainly recent, and here is your general results, that the seizures in these patients who were quite complex epilepsy patients, so again, I didn't mention that, but the population was patients that had drug-resistant epilepsy with syndromes such as Dravet syndrome, Lennox-Gastaut syndrome, so these are syndromes with a lot of seizures. It looked like when we treated these children, more or less, the seizures were reduced at the same rate of the established anti-epileptic drugs. And more importantly, it was safe and it was tolerable in this population. And you can see here the effects were kind of mild to moderate related adverse effects. So some adverse effects are there, but they're mild, moderate, and seizure control was just as good as the other epilepsy drugs. And in some cases, I always like this stat because it gets lost in the noise of these studies sometimes, is that consistently in all these studies, about 6 to 8% of these children were seizure free. These are kids who have been on a lot of drugs over a long period of time, and about 6 to 8% became seizure free with cannabis. That tells me that cannabis it works for seizures if that's happening and that's the only intervention when you compare that to a placebo. So that's a pretty good stat to remember. Now, when we try to compare these things, purified CBD and CBD-rich extracts, as I said, this is the biggest, most contentious point in cannabis probably right now, or one of the biggest questions to answer. When we look at the rich extracts versus pure, so again, the rich extracts are going to have THC in them. It looks like about the same number of people respond, but look at the dose difference. You need a lot less CBD than you do when you're using a purified CBD solution. So this is interesting. And as you look at the adverse effects as we go up to higher doses, it looks like there's more adverse effects. So overall, this is a question here, which one is better? We need a head-to-head trial, and there are some in the works throughout the world that are trying to answer these questions about pitting the CBD-rich extracts versus pure head-to-head to see if there are different results. Really complicated stuff to do though, and it's going to take a lot of time and a lot of meticulous studies and a lot of dollars spent in order to answer this question, but a very important question to answer. Okay, I'm going to end with this case because I said I wanted to show this case. I think it's really important. This is Quinn. She presented to me a few years ago as a 2-year-old with an explosive onset of seizures. She was a normally developed, functioning young little girl who out of the blue developed seizures. We tried some anti-epileptic drugs, didn't work. Worked to control partially, but not completely. Okay. Now, there she is walking around. So when you are a normally developed individual and suddenly have a lot of seizures that give you an EEG that looks like that, which is a really bad EEG, over time, your brain stops to develop normally. And as a child, that means losing developmental skills. So you can see her there. She's kind of stumbling all over the place. She was walking perfectly normal before her seizure started. And the ongoing abnormal electrical activity in her brain caused her to start to degenerate in function. That's her mom there. Her mom has been a massive advocate for Quinn and a partner here with me in helping Quinn. And she took the giant leap to try to cannabis with her child. Now we started cannabis, that's the EEG before, that was the EEG after. Her seizures stopped within a couple weeks. The EEG went from being abnormal to normal. And more importantly, when before she was having difficulty kind of just walking around, within 2 months, she was out and behaving totally like a normal. I think she was almost 3 years old at that time. And she went on to be seizure free for 12 months at a dose of 8 milligrams per kilogram per day of CBD. No other anti-epileptic drugs needed. We took the rest off and she continued to be seizure free. Now here's where her story gets even more interesting. At 12 months, her seizures come back out of the blue. They come back 6 to 7 times per day. All those deficits neurologically that I explained before, that you saw before, they came back. She was having trouble writing and walking. Her EEG became abnormal again. So it went from being normal to abnormal. We tried to increase the CBD, didn't work. We tried this cannabis receptor reboot, which you may have read at other times. That didn't work. All right, well, there's her EEG. So her EEG starts to be abnormal again, doesn't look very good. So what did we do? Well, my thinking was that we just overloaded with too much CBD for various many reasons, which we can get into in the Q&A. So I thought, well, what we need to do is we need to balance the system. When you have knowledge of this, you have a bit of understanding here, and balance it with some THC. So we added THC at night. She had immediate reduction in her seizures and became seizure free within 1 week of just adding more THC. And all of her neurologic deficits resolved. And at that time, Quinn's mom said she's the best she's ever even seen her. And there she is, pre-THC, post-THC, EEG normalizes. All right, now it's even more interesting. So from that point on, from January 20th, that was her dose there. She was on 5 milligrams per kilogram per day of CBD and 0.2 milligrams per kilogram per day of THC. She went seizure-free for another whole year. Normal development and function. February 2021, she gets her breakthrough seizures, very similar like she did in December 2019. Same type of events, multiple per day. The EEG becomes abnormal again. Now, she gained weight in that period of time, so her THC effectively dropped. So did her CBD. I held the CBD, just increased THC only, seizure stopped immediately again. As you can see there, February 2021, she goes back up on the THC. So it went from 0.16 to 0.48, CBD unchanged, seizure free, neurologic deficits are gone. Her EEG normalizes again in March 2021, and she's been seizure free since. So really important case to present because there are some key questions that arise out of this whole medical cannabis journey in epilepsy. One of them is, what is the role for THC? Clearly there's a role. I've seen too many patients now who are THC responders like Quinn. They don't make up a massive proportion of the cannabis patients I work with, but they certainly make up some. It certainly is an effect that that can help. It's something we have to take very seriously and explore. Never mind the list of other questions I have here, which are extensive. Okay, that's it. I tried to get through that quickly. I probably went a bit over time. Thanks for your patience. I think it's really important to always present a case and set that stage there. So Mike, if we go a bit over time, then you and the rest of the panelists can blame me, but I appreciate everybody else's time.
No problem. Thank you very much, Evan. As usual, it's beautifully clear and sets the scene. And that last case, of course, illustrates the real benefit and quality of life that can follow from prescription of cannabis. Not for everybody, but and also the benefit in many people for the addition of a little bit of THC as well. So thank you so much for that. We'll move on, if we may, to Charlotte Moore Hepburn, again from the other side of the pond, as they say, from Toronto. Charlotte, thank you so much, first of all, for joining us tonight, lunchtime for you. Charlotte's the lead for child health policy at the Hospital for Sick Children in Toronto, and assistant professor of pediatrics in the Department of Pediatrics, and of course a practicing pediatrician, and also involved as the Director of Medical Affairs for the Canadian Pediatric Society. So Charlotte, you're going to tell us, thank you, about your experience on medical cannabis, as it says there, on the front line. So we would love to hear that, because we've had so many problems in the UK. We'd love to see how you've coped or not coped, and the experience from Canada. So thank you very much. Over to you.
Thanks so much for having me. I feel like I should probably start first with a disclosure, and that's that I'm not a neurologist, I'm not an oncologist, I'm not a pediatric palliative care physician. I don't even have a specific clinical or research interest in cannabis. I am an acute care hospitalist pediatrician at a large academic tertiary hospital, and I would say that in 2021 in Canada, if you are a practicing pediatrician, even if you don't have a unique interest in medical cannabis, there is an obligation to know and understand it because its use has become so widespread among so many different categories of pediatric patients. And becoming comfortable and knowledgeable, I think, is probably one of the most important things we can all do, because this landscape changes very, very rapidly. And one of the things I have learned is that without knowledge, we are quite powerless. So to take you through sort of this speed of light journey in Canada, medical cannabis has been legalized since 2001. That really does seem like a long, long time ago. When medical cannabis was legalized, that was the year I graduated from medical school, and it was completely absent from the curriculum and certainly nowhere on the pediatric landscape in terms of training or education. 2006 wasn't a particularly remarkable year in the medical cannabis journey, save for the fact it was the year I got my first faculty position and started on staff. And I can safely say that for the first several years of my faculty training or of my faculty experience, I didn't have a single patient who I was aware was taking cannabis. It was absent from my landscape. Within 10 years, though, that had completely changed. By 2016, we had so many patients at our hospital who were taking medical cannabis that we actually had to form a medical cannabis advisory group and come up with clinical practice standards for how we were going to manage in the hospital setting patients taking cannabis, because none of us had any significant experience with this particular medication. That went on warp speed once 2018 hit, and there was the legalization of recreational cannabis, when we realized not only that cannabis was becoming more and more prevalent in society more broadly, but people became much more open about sharing their cannabis stories with us, having previously been administering cannabis to their children and simply not disclosing it to medical personnel. That brings us to 2021, where on a day in rounds, especially if I'm on one of our complex care wards, I could regularly have 25% of my patients taking some form of medical cannabis. And there have been days when I have rounded when more patients have been on medical cannabis than not. So things have changed a great deal in the last 20 years, and hopefully you can learn a little bit from the Canadian experience. There's only been one survey of Canadian pediatricians that has looked at how prevalent medical cannabis use is. It was done in 2017, which is the year before recreational cannabis was legalized. And back in 2017, of 835 pediatricians, that's about between a half and a third of all pediatricians in Canada, 50% of them responded that they had at least one patient taking medical cannabis. So before legalization, 50% of pediatricians in Canada were aware that at least one of the patients in their practice was on medical cannabis. The vast majority did report that they had 5 patients or less, although a significant number, so 35%, would have had more than 5 patients in their practice on medical cannabis. But what was most interesting about this data was that only 34 of those pediatric providers had actually been the ones to authorize it. So you have 419 pediatricians reporting that in their practice there are patients taking this medication, but they're not the ones doing it. And I think that really led us at the Canadian Pediatric Society to pause, take a step back, and look at the broader context. And that's lesson number 1 that I would leave you with tonight. And that's, if not with us, without us. We realized quite plainly that if parents or patients themselves desired medical cannabis, they would look outside the pediatric community if we were not willing to talk with them, counsel them, share what we know, and walk on a journey together. Especially now that cannabis has been legalized recreationally and avenues to cannabis are widespread. If we don't jump in with both feet and be willing to walk with our patients to hear their concerns, both their concerns with their current medication regimen and their interest in their product, they will pursue this without us. And I think it's hugely important recognizing that many of these patients have medical fragility, many of these patients experience polypharmacy, and many of these patients would like to speak to their medical provider about their interest in cannabis. We owe it to them to learn together. The second thing I would say that's been hugely important to us that we've learned about is that nature abhors a vacuum. In the absence of our transparent professional conversation, misinformation will flourish. From that same CPSP survey, we know that about half of all pediatricians, those with kids on medical cannabis in their practice and those without, believe that there probably is some role for medical cannabis in the mainstream medical culture. And they would name conditions like refractory epilepsy or refractory spasticity, palliative pain, or non-specific neuroirritability as conditions where current medical therapies really are suboptimal. The medications in our armamentarium usually do have pretty unfavorable side effect profiles. And cannabis has, both in the evidence and anecdotally, created relief for patients and families. What's of greater concern, though, I think, for general pediatricians is that in the absence of us acknowledging that there may be a role for medical cannabis in certain conditions, it will flourish in other areas. Those same 800 pediatricians reported cannabis being used by their patients for conditions that ranged from headache, general anxiety disorder, social anxiety disorder, conduct disorder, ADHD, and autism. We need to stick to where the evidence exists We need to acknowledge and we clearly articulate where evidence does not exist and manage this as we manage all other medical information. It's not a panacea. It's not going to cure all things. It clearly, though, does have effects and side effects, and we need to know and understand enough to have those open conversations with our patients. If we don't, misinformation will most certainly fill the void. And lastly, and perhaps most importantly, as an academic general pediatrician, I think it's important to recognize that a drug is a drug is a drug. And if we are ever going to get to a point where we can confidently understand, prescribe, and manage patients on medical cannabis, I think it is best to understand, prescribe, and manage it as a drug. One of the things Canada did in those years between medical cannabis authorization and recreational legalization was to develop a unique freestanding therapeutic product space for cannabis. And that has proven quite problematic for those of us that operate on the front lines. There are enormous benefits that come from appropriate regulatory oversight, appropriate quality standards, and appropriate reimbursement pathways. And without those three aspects in place, it's enormously challenging for patients and families, physicians, and healthcare institutions to manage a different type of product. In Canada, what has happened is multiple licensed producers are providing multiple different products. They go by different names, they have different THC to CBD ratios, they have different concentrations and different excipients, and there are different terpene profiles attached to all of them. This is so different from how we understand all the other medications in our toolbox. Clonazepam is clonazepam, ceftriaxone is ceftriaxone. And in this space, it's quite opaque for those of us that are non-expert, but still managing patients who are being authorized by others. I also think it's important to acknowledge that in Canada, when one authorizes, they authorize in grams of dried cannabis, as opposed, and how it's authorized is very different than how it's dispensed or prescribed. So in addition to the variety of different producers producing a variety of different products, all of which have subtle differences, but important differences, the way it's authorized and the way it's prescribed and dispensed, it is ripe for error. So the more user-friendly the regulatory framework can be, the safer it's going to be, and the greater trust providers will have in the system. I won't spend a great deal of time articulating the differences between GMP production quality standards and GPP quality standards. Suffice it to say that a drug is a drug is a drug, and we need to make sure that there isn't interlot variability or contamination, and providers need to have the same level of confidence in medical cannabis products as they do in the remainder of drugs that are on the market. And lastly, and perhaps most acutely, it's important that these products be managed as drugs so that they can undergo the regulatory processes that can afford them a DIN. That's what we call it in Canada, a drug information assignment that our Health Canada provides to them that allows it to be reimbursed appropriately. Cost is probably the most significant barriers for my patients. And when we're caring with patients who are coping with life-limiting conditions, sometimes with extraordinarily challenging to manage spasticity or chronic pain, seeing cost as a barrier is particularly concerning. So I'll close by saying that what we see is a product that has both effects and side effects, and it behooves us to understand what they are, because the conditions that they're currently used for are suboptimally managed at present. The medications that are currently in our toolbox often have a non-favorable side effect profile. And if there is potential and promise, we need to walk with our patients and find the best path forward. Thanks very much.
Thank you, Charlotte. That's great. Thank you so much for sharing that. And I think the particular lesson, I like your lesson one there, if not with us, without us. And I think those who are reluctant to prescribe do need to remember that desperate families or desperate patients for adults will go to the black market in the UK. Of course, it's not legal recreationally. Will go to the black market and get this for their child, and I would. And I think we need to recognize the downside of not prescribing. So thank you very much for that very clear presentation. We're going to move on to Matt. Matthew, actually, it was just briefly to say that Hannah Deacon was on your program. She's unfortunately unwell today. So Matt has very kindly stepped in, not quite at the last minute, but in the last 24, 48 hours. So Matt, thank you very much. If you come on screen, Matt is where are you? There you are. Matt is very expert at cannabis, I have to say, very knowledgeable. He is a parent, no doubt he will tell you himself in a moment, parent of a child with epilepsy, who has learnt, as many parents do, of cannabis by himself, self-trained, self-taught, and like many of these parents now, extremely knowledgeable, and frankly, a lot more knowledgeable than most of the doctors. So Matt's going to tell us a little bit about his experience and how we can get, or cannot get, as it were, a prescription for medical cannabis for a child, particularly with epilepsy. So Matt, thank you again for stepping in, and all yours.
Oh, hi everyone. Yeah, so as Mike's just briefly explained, my son was diagnosed with infantile spasms at 10 weeks old. He was suffering, cutting a very long story short, but he was suffering up to 120 seizures per day. And then we started a private prescription for cannabis. We started over-the-counter CBDs at first with not a huge effect. But then when we started prescription cannabis, his seizures reduced. And for 2 years now, we've been using a private prescription, and those seizures have remained below 20 from 120. So it's a big difference to our life and obviously to his life. So we've been battling for access on the NHS because paying privately is, as all parents, is really, really difficult and brings a lot of strain to the family and everything. So I just want to talk about, there's lots of talk, especially within MedCan and outside of social media, about why is there no NHS access. So I want to kind of try and show the routes to why that is happening at the moment and the blockages, and also talk briefly about the private access and the difficulties at the moment within that. So I'm just going to open up my slideshow. Okay. Is that working? Okay, right. So at the moment on the NHS, we have one licensed medicine. There are others, there's Sativexis for MS, but predominantly for epilepsy, we only have Epidiolex, which is classified as being licensed and commissioned on the NHS, or in brackets on tariff, as it's also known. When we talk about other medications, so these are the ones that are prescribed privately. So you have Celixa, Vegelite's a popular one, Bol, Afia. These are all unlicensed and non-commissioned and off tariff. That's the important bit, because the commissioning deems how it's funded on the NHS. So once it's commissioned, NHS can fund it. If it's non-commissioned, they can't fund it unless the individual can show exceptionality. So this is where all the blockages and all the hoops that we're having to run through, clinicians as well, not just parents. So for a medicine to come into, or to be available in the NHS, there's the European Regulatory Framework for Medicines. So it starts with your pharmaceutical, your evaluation, authorization, access, reimbursement, and safety. So this was yesterday on epilepsy research with GW Pharma, who produce Epidiolex. They had their own webinar similar to ours, talking about Epidiolex and the route to cannabis-based products on the NHS. So in the UK, or in England, should I say, it looks a little bit like this. So you have the licensed producer who would have a randomized control trial, roughly around 500 patients in that trial. Obviously, the trial will cost millions of pounds to run. But it would also have set outcomes within that trial. MHRA would then license that medicine depending on the outcome. Let's assume it's very positive. NICE would then evaluate the cost effectiveness of that product. They would then write their own guidelines and they approve for commissioning. The NHS will then commission that medicine, and under the Health Act 2006, that allows that NHS and CCGs to fund it in the normal way. So as any other medication is available in the NHS, but because products at the moment haven't been through that process, that's why it's not happening. So as a result of this, just quickly jumping in, Professor Adam Cross also mentioned yesterday that with the current guidelines from NICE, which is at the bottom there regarding THC and CBD, but predominantly the effects of THC on the brain and the lack of evidence in that area. So there's a need for extra trials within the UK. So this is kind of what it looks like for parents and clinicians to prescribe. So I'll quickly run through this. Local clinicians need to refer to a tertiary neuro centre. So for us, we are based in Norwich, our local hospitals, Norfolk and Norwich. Our clinician there would need to refer to Addenbrooke's, which is our local or East Anglia's neurology centre. So tertiary neurologist can prescribe, but is advised to seek advice from RESCAS. RESCAS is basically a panel of 11 neurologists here in the UK, 11 top paediatric neurologists, and they don't see the patient in person, but they'll review the history of that patient and they will give their recommendations. Upon approval, that neurologist can prescribe, but they have to refer to the chief pharmacist of that particular trust. The chief pharmacist will then run that past the trust, make their approval, and then because it's not a non-commissioned medicine, an independent financial request is then required. That independent financial request requires that individual to show exceptional reason, to make them a part of everyone else as to why they can access the medicine and be funded by NHS England. So at the moment, there are only 3 children in the UK that have met that need. As I say, we've been through it, many other parents have been through it and been refused because we can't show that exceptional need. And as I said at the bottom, the IFR panel, you reach a screening panel first. If you're successful through that, you then reach the independent financial request panel for that final decision. So how do we get around this? Ultimately, the NHS, MHRA and NHS England need to consider and understand why we do not have RCTs in full extract cannabis. They also need to build a framework around botanical medications that's needed to allow commissioning of full extract oils for childhood epilepsies. As already mentioned by Evan, cannabis is unique. It's not a normal medicine. It's different to most other pharmaceutical medicines available on the NHS. And it's got multiple pathways and acts on several different receptors within the human body. So it's not like any other medicine either. So we're trying to treat cannabis like a normal pharmaceutical medicine, and we're trying to push it through the routes of a normal pharmaceutical medicine. And that's just simply not working. So 3 years down the line, since the law changed to allow prescriptions, nothing's changed. So then within the private sector, we currently have 3 doctors, paediatric doctors. We have Dr. Martinez at the Portland Hospital. She has about 20 patients. Her books are full and she's semi-retired. Dr. Hassan at the Medical Cannabis clinics, he has 40 plus patients. But the BPNA initiated GMC investigation. He's no longer able to prescribe for any further children, although he can continue prescribing for the current children. That leaves Dr. Berry at Sapphire Medical Group being the only paediatric neurologist for the whole of the UK privately who can prescribe. So with no NHS access, we're now left with only 1 clinician. As already mentioned, paediatrics are not available on Project 2021. And yeah, so we're just left with 1 doctor for the complete whole UK. So in just comparison as well, we have 50 clinicians prescribing for adults, and many of them were in Project 2021 with capped costs. So what's the impact of this? So the access of a variety of cannabis-based prescription medicines are restricted. Parents are forced to use over-the-counter unregulated CBD oils or go to the illicit market. Further harm is caused with no clinical expertise, so interactions, dosing, that sort of thing. Parents are turning to organisations like MedCan and PLE for clinical advice. We're not doctors, but they've got nowhere else to turn to. If they can't see a clinician, they're having to turn to other parents for advice. Children returning to seizures are not having the option even to try cannabis. Lack of prescribing leads to little research and little evidence. Social impact on the families, their mental health, the financial strain. And again, back to Project 2021 with cap costs, the data gathering and that extra evidence. And that is it.
Matt, great. Thank you very much. That's a beautifully clear explanation of what is actually a very complicated field. No wonder your people can't work out how to get this done. They've got to wade through a maze of bureaucracy. Sorry, this line down me is called the sun, and it's a very unusual thing in Newcastle. We haven't seen it for about 9 months now, so it's actually getting in the way. But Matt, thank you very much for that. We're going to pass on quickly because it's 6:20. I want to get Callie to say a few words before we just open up to the panel. We've got a few questions already. So Callie, where are you? There you are. Good. Callie Seaman, Dr. Callie Seaman is really well known in the hydroponic industry, if I might say so. She's worked in that field for a long time, a PhD in hydroponics, if you like. Set up something called Aqua Labs, her own company, and now working in a lot of other companies like Empire as well. But for relevance today, so she's very knowledgeable in medical cannabis full stop and the growing of the plant, but also is going to tell us about her own experience for epilepsy and what the good things and perhaps the difficulties she's encountered along that path. So Callie, again, thank you so much for joining us. And if you're going to tell us for a few minutes about your experience, thank you.
Thank you for having me. I've got no slides today, so I'll make this as brief as possible, but I'm going to tell you a bit about real world experience and what I've experienced. So at the age of 15, I was diagnosed with epilepsy. I had what we called then a grand mal at school. And that was back in 1995, before we even knew the medicinal properties of cannabis or even were able to discuss them. I was then quickly put onto carbamazepine, diagnosed with a low threshold to epilepsy and found to have a slight slowing in the front right lobe of my brain. As I say, very quickly put on to carbamazepine. And my GCSEs unfortunately suffered dramatically. They went down from grade A's really down to your C's and your D's. But I was very fortunate to have a father who was very forward thinking and introduced me to cannabis at that point and always told me to consume to make sure to keep my seizures at bay. At 17, I was taken off of carbamazepine and I returned to normal. I felt like I was me again. I'd lost a really big part of me when I was put onto the anti-epileptics. I went on for many years not to suffer from any seizures or what I thought were seizures. And it wasn't until I was in my 30s, I was 35 and I was in the middle of doing my PhD, trying to complete it, and I'd actually stopped consuming. I made the decision I needed to clear my mind and actually start really writing up my thesis. Unfortunately, I had a tonic-clonic seizure at work and smashed my face up and knocked my tooth out. Still at this point, this was in 2015 this occurred. We didn't have access to any medical cannabis. The law hadn't changed and we still couldn't really talk about it. So I sort of started doing a little bit more investigating, but was still really in denial about my epilepsy. And it wasn't until we started to see the CBD come onto the market and what was happening over the pond, what was happening in the US with Charlotte's Web, and that there was some science to this, and started to investigate this more. Now, obviously wanting to concentrate more and not really wanting to go to the illicit market, I went on to using just CBD products, Charlotte's Web starting off with that. The problem with that was, again, my seizures increased and it didn't do everything that I needed it to do. I would find that I wasn't sleeping properly. Now, with someone with epilepsy, and anybody with epilepsy will know that sleep is like gold dust. It is number one rule. Getting enough sleep can actually prevent seizures. Now, it wasn't until there was a law change in 2018 that we thought brilliant things were changing. So I spoke to my doctor. My doctor wouldn't interact at all with me. We just told me that this was illegal and it was not to actually talk about that. It was a really, really difficult conversation. My neurologist was the same. I spoke to her about my use of CBD products and she was just, again, obsessed with putting me back onto pharmaceutical anti-epileptic drugs. And I wasn't happy to do that because of what I experienced as a teenager. So I carried on, and then luckily we started to see the private clinics increase in this country. And at the beginning of this year, I actually went to the medical cannabis clinics and was prescribed. Now, the biggest issue I found with this was the lack of information that I got with it. The products that I got through only told me about the CBD and THC content. Now, as you heard earlier by Evan, that there is over 400 different compounds within cannabis that are all of different ratios, and will all have a different interaction with one another. If all we're looking at the THC and the CBD, how do we know that that is the correct medicine for myself? So I wanted to actually understand more and more about what I was actually taking and what I was finding was working for my condition. Over the years, I'd actually found that particular strains were causing more problems. When I actually came out of denial in 2015, I started monitoring what I was consuming. I started to actually look at the strains that I was using. And I found particular strains like Testarossa would cause an increase in my seizures. But then I would find others, such as the MAC, would actually decrease my seizures and help with my sleep. But I wasn't getting some of the difficult side effects. Now, this was one of the problems that I actually found with going to the clinics, was the lack of actual choice and lack of real understanding there of each of these different strains. This is only based in the UK, and I'm hoping that we will actually change and we will actually go more towards the Canadian, where there is a better understanding in each of these products and more products available to us as well. I mean, I've not even actually mentioned the cost that goes into this as well, which makes it also prohibitive as well for myself. And anybody who is on a low income certainly wouldn't be able to do this. So going forward with my experience, what I want to see is, I would love to see more information coming through on these particular products that are coming through, particular strains, and being able to work more closely with my NHS doctor. I want to see them educate themselves, because it's almost embarrassing going and you're trying to tell them that you're using this and they won't even put this down onto our records. Hopefully this will change, and hopefully with the work that Project 2021 is doing and the work that Mike Barnes is doing with the MCCS as well, will help to educate these GPs and get more people, to more actual doctors prescribing and more confident with what they're doing. I hope my experience has helped, and if you've got any questions, please feel free to put them into the questions section.
Lovely. Kelly, thank you so much for sharing that. And I think the point you make is good, that, you know, the plant is so complicated. We almost have a right, I think, if we're using it for ourselves or our children, to know what's in it. And I have to say, there's a lot of criticism around the neurologists. We also should criticize a little bit some of the licensed producers who really don't make available to us the knowledge of what's in the product. We really do need a proper full exposition. That could be a certificate of analysis of what minor cannabinoids and what terpenes are actually in the product, and that we'll only knowing that, we'll find out more about which particular products help most people, and that's something that's going to slowly emerge over the coming years. We've now got some Q&A to go through. If you could put any questions in the Q&A box, not the chat box, the Q&A box, and if everyone puts themselves, or the panel now could put themselves back on the screen, that would be great. And off mute. Panel, thank you very much. And we'll just go through some of these questions. We'll probably overrun a few minutes. We usually do. I warned you earlier. I promise we'll have a definite hard stop at 1:45, if not a bit sooner. So let's just start at the top. A question here, amazing. It says, how do parents afford the treatment? Well, that's a very good question. A lot, of course, can't access the treatment because they can't afford it. Of course, it's all private, except the 3 that Matt mentioned. And there's all sorts of sad stories, isn't there, Matt, about people selling houses, selling businesses, coffee mornings, fundraising, which is absolutely disgraceful. People, when it's a legal product, should not really be doing that. And of course, they've been impacted by COVID when they haven't been able to do things like coffee mornings and fundraising. So Matt, do you want to say anything else about the affordability?
I think you just covered it really. Yeah, it's basically fundraising, GoFundMe. Some people like whole bingo nights and things like that. Yeah, it's literally just trying to get friends, family, and support on social media to try and fundraise, basically.
Yeah, which is really appalling, isn't it?
Yeah.
Let's move on to the next one. An anonymous, but what are the links, if any, between the medical use of CBD in children and early onset puberty? And if this is something that parents should be aware of or concerned about, are there any associated health risks with early onset? Does Charlotte or Evan want to answer that
Yeah,
one?
I can respond to that because I get that question sometimes. I know this recently is coming from actually a UK case. There's a 2-year-old where there was a case report, I think, published of a concern for early onset puberty in a 2-year-old boy who was being treated with cannabis. So one to say is case reports are important. They're important because they give us a bit of signal. So certainly that raises the question. I would agree. I think that's an important question that needs to be answered. And if you look back into the literature, there has been some analysis on this. Unfortunately, the analysis turned up that we don't have any information about this at all. I think there's a systematic review from either 2018 or 2019, and they looked at gathering papers to answer this question. And there was actually not a single publication that looked at kids on cannabis, following them out and looking at outcomes regarding puberty. The focus was more on kind of intellectual capacity and behavioral mood issues and stuff like that. So I think it raises a question. I'm not an endocrinologist. I think it would be a good question to pose to an endocrinologist, a hormone doctor who has expertise in cannabis, to see if there's actually a mechanism there by which this could make sense. So right now, I would say the answer to that is we don't know. It's something to consider. It's a question there, but I think when you look and read the case reports and the headlines that came out of that, it's a bit misleading. It tells you right away from this one case that cannabis is linked to early onset puberty. I don't think we can say that. I don't think we say there's a link. I think that case report shows us that there's a potential that this might be a side effect or an effect of long-term cannabis use. And it's something that we should explore. And we need to ask our fellow endocrinology colleagues to start looking to this and see if there's a case. And there might be there are some animal studies that show potentially this is a possibility as well. But again, that data is not translatable to humans.
Great, thank you, Evan. Next question was really just to thank a brilliant information from the panelists. Great insight, thank you. Shall we jump to the next one? Can members of the panel confirm if, in fact, product availability to the UK from Bedrocan has been extended beyond the 1st of July to the 1st of January 2022, and is this company intending to set up an outlet in the UK? For those who don't know, this was an issue post-Brexit, where there was a difficulty getting Bedrocan products which are made in Holland from Transvaal Pharmacy into the UK. There was a campaign led by Hannah again, to move that, and the government last week, I think it was, said that they would extend that deadline to the 1st of January to give themselves a little bit more time to sort this out. And I believe that the company in Holland, Transvaal, is intending to set up an outlet in the UK over the course of this year. And hopefully that will happen and the Bedrocan issue will go away. One keeps one's fingers crossed, but that is, I think, is the current situation. Matt, do you have any further information on that?
Yeah, it has been confirmed that prescriptions in Holland for the current children that are being prescribed, it has been extended to the 1st of January 2022. So I don't think that new prescriptions, only the existing prescriptions.
We have a bit of breathing space, but it's a very unsatisfactory situation. So that's when fallen foul of both COVID and Brexit. But I won't get political. I usually do manage to get political, but I shall avoid it. Another one here, is this setting the stage for Big Pharma to be responsible for the source of cannabis meds, especially isolate compounds? Anyone want to answer that one? Callie? Is Big Pharma going to put its big boots in this field? Callie, you're on mute.
Typical. It already has, unfortunately, in the UK. I hate to say it. We are, unfortunately, the only licensed medicine is Epidiolex from GW Pharmaceutical in this country, and I'm hoping that is going to change. I really do hope it will change in these coming years. As we saw the change happen in Canada, there was a ramping up in the actual accessibility to products, and hopefully there'll be more license granted, but unfortunately, actual cultivation licenses that have been granted in this country are limited. I believe there's only 5 now. A majority of those are only research. So there's the issue of actually supplying the product, even though it's cultivated in this country, it's being able to supply it to the actual patient.
Yeah. I think it'd be a shame if we pharmaceuticalize cannabis. I for one would think that's very sad. because it doesn't lend itself to the pharmaceutical paradigm. It's a plant, for heaven's sake, and we need an approval system and a research system and a licensing system that recognizes a botanical product and not try and shove it down a pharmaceutical route. Next question, why don't we get a proper terpene profile with every product? I think absolutely right. Why don't we? Ask the licensed producers. I think there will be pressure on them, and there is pressure from Matt and MedCan Support, for example. I should have mentioned MedCan Support, Matt, shouldn't I, that you set that up, which is an excellent information and lobbying organization. And I think you're pushing for that. And I think through the Medical Cannabis Clinician Society and other bodies, we will certainly push. I think we absolutely need a proper terpene profile for every product and a profile of the other minor cannabinoids. You know, I think that's all I can say at the moment. We haven't got there yet, but we're certainly, all of us are going to push for that. Yep.
Yeah, and then just to echo that, and I think Charlotte, you had mentioned that you had made that point very clearly that, you know, in Canada where we have so many different products. The same thing there. Mark, who asked this. Some companies publish their terpene profile, others don't. That makes it really difficult for me when I'm prescribing, because I utilize the medical aspects of the terpenes in making decisions for my patients. And in some cases, cheaper oils or more affordable oils, I can't prescribe to patients because I don't have the terpene profile, and I don't really want to do that. And so that comes back to what Charlotte mentioned before, you know, the importance.
Absolutely.
So, something not to do in the UK, if we can.
Unfortunately, they see terpenes as a contamination here. Unfortunately, that's what they're classified as.
Yes, crazy. Next question, a bit of a political one there. How do we lobby the government to get them to look at changing the antiquated drug laws? Well, that's a very good question. Many ways to do that. There is a sort of slightly more formal way of trying to influence right to the government, go through the parliamentary groups, the all-party parliamentary groups on medical cannabis and drug policy reform. I hope some of the bodies we've talked about, like MedCan Support, the Cannabis Clinician Society, and the Cannabis Industry Council, which is now being formed and is 94, I think it is, entities. We're beginning to, in the industry, to speak with one voice. We need to lobby government in that way. There's a direct patient power as well. You know, I'd encourage parents to go and sit in the offices of the BPNA and not move till they've pulled themselves together. But I'm sure I shouldn't say such a dreadful thing. But this industry has been led by, if you like, patient power, patient influence, patient lobbying. And I think that's got to continue alongside perhaps the more formal lobbying. So that's what I would encourage, is people to go to their neurologist and say, I want this. And not take no for an answer, basically. If anyone else has got any views on that, I'm advocating patient revolution, I suppose, aren't I?
I'm with you there. And something I saw you give a talk once, Mike, and encourage, say, get some peer-reviewed journals and take them with you to your doctor and ask them to explain them to you. And we've got a database on the MedCan website. Please download them. Please take them with you, so you have got evidence, hard evidence, that those doctors will respect, not just you know, some print off from a website like Leafly. Take the peer-reviewed journals, hard data. Look up Evan Lewis's research. Get some of his stuff. Take it with you. They can't argue with it, and just ask them to explain it to you. It's so powerful.
Yeah, and if I could kind of speak to that too, and I think, again, this is another point, you know, Charlotte brought up, like some of the difficulties for the frontline physicians in Canada is that this came so quick and so fast from the grassroots up that the physicians were unarmed with the proper amount of knowledge to be able to cope with that. So I agree with you, Callie, that's really important. But I would encourage anybody out there who's listening, if if that is something you're going to do, just be very cautious of how you approach that, right? You have to, and I give this talk, and I think Mike and Matt have heard me give this talk before, that there's two sides to the coin. As much as, you know, the parents and patients live in their worldview, doctors and physicians have their own worldview, and you don't want to create this Mexican standoff kind of, you know, type of analogy where you know, who's going to draw first, and because you're going to just you're going to push the doctor back on his or her heels and make them feel really uncomfortable and defensive, and then you're not going to get anywhere with that. So it's good to be armed with knowledge, but it has to be treated so delicately, because we have to also respect the worldview of the physician and where they're coming from. Here's you coming from a time in which they were told, and as Charlotte mentioned, like our school and education, we're not taught this. And if anything, we're taught the opposite, right? For a long time. And we grew up in a time where we were exposed to, advertising and media and how bad these things were. So it's a real shift. And I think both sides, we have to treat that delicately, and both sides have to see their own view and the other individual's own view and work together. And that's where I've seen the most successful relationship.
Yeah, exactly. Exactly.
Yeah.
I would say it's almost indisputable that these products have effects, both positive and negative. And anything that has an effect has a side effect. And anything that operates like a drug in your body is going to have drug-drug interactions. And until we have a solid research and evidence base that allows frontline providers to understand how the drug works, how the drug interacts with other medications, and what side effects they have to look out for, it's going to be incredibly challenging to allow mainstream providers to actually engage in this space. We have an obligation to understand those three things. What I would say is that that's identical to every other medication that we use. There isn't a single other medication that doesn't have drug-drug interactions that we need to be conscious of. And there isn't a single drug that doesn't have a side effect. And many of those side effects are incredibly negative. So the possibility of negative side effects shouldn't stop us from pursuing this. And the possibility of drug-drug interaction shouldn't stop us from pursuing it. It's by knowing and understanding those things that allow us to actually prescribe, dispense, authorize them safely.
Yes. Thank you for that. I'm going to try and stop us in 5 minutes, but we've got about another 5 or 6 questions. I'm going to quick one-word answers for these guys. Are people allowed to grow their own cannabis legal in the UK? I'm sorry to say the answer to that is no. That's a different debate, but the answer is no. Someone's moving through these remarkably quickly. Are there cases where people have suffered side effects from cannabis treatments? Well, yes, is the quick answer to that. I mean, no medicine, as Charlotte's just said, is safe. There are side effects of cannabis. It's not right to be prescribed for everybody. I'm sure everyone would agree with that. I mean, we got not time now to go through what those side effects are, but clearly, like any medicine, there are side effects. Following the law change, first of all, why is it all GPs in the UK Crown Dependency of Jersey can prescribe? Sorry, I don't want to answer all these myself, but I will answer this one. It is a Crown dependency. They can set their own laws, their own regulations in Jersey and Guernsey and the Isle of Man, and they have done so. And Jersey, and I'm not sure about Guernsey just at the moment, I think it's about to, but Jersey certainly GPs can prescribe. I think it's a shame that GPs can't prescribe in the UK, not necessarily for complicated, very specialist pediatric drug-resistant epilepsy, maybe not, as GPs won't tend to understand the nuances of that, but I think GPs certainly should prescribe for things like chronic pain and anxiety, which is a GP area, really. I'm going to move on quickly. How will we all know what compounds are in each product and a description of what they all do? Anyone to answer that? We've sort of answered that, I think. Matt, do you want to go with that?
There's something we're working on in MedCan and through the CIC, which Mike has set up. We just need the LPs to be testing these oils to understand what is in, what phytocannabinoids are in them. As to regards to the description of what they all do, I don't think that would be able, the LP would be able to give that because it's quite detailed and technical. But again, that all information is available on the website and other areas as well. Within the Google chats, etc. So it's not happening basically at the moment.
We hope it will. That's one area we can influence. Just a quick one. I thought it was quite a complicated answer. I'm going to pass to Matt again, who's our expert on exceptionality. What would be considered exceptional when NHS approving for non-commissioned prescrips? That's a
very easy answer. We don't know.
Yes.
So it's basically we don't know.
It depends who's on the panel and how tuned they are, frankly.
There must be some criteria that they have to go by, but
they don't publish the criteria, and it is a bit luck of the draw, which is appalling, but that's what it is at the moment.
Yep.
Why are pediatric neurologists unwilling to discuss or even prescribe even Epidiolex when that ought to be more readily available? Is it a cost issue? Anyone to go with that? I think the answer is that they look upon it as a pharmaceutical product. They look at the number of double-blind placebo-controlled studies, and they don't take any notice of real-world evidence, as now called, and dismiss all real-world evidence Literally, even NICE did all that in their deliberations. They dismissed real world evidence and just looked at double-blind placebo-controlled studies as if it's a pharmaceutical product. I think that's the main reason. To be honest, there may be other reasons, but I think that's probably a main reason. It's an unwillingness to embrace what is actually a new medical paradigm, if you like, a new medical product. I said I promised to finish. I've got 55 seconds now. How do existing patients under Project 21 put themselves forward to be considered for a case study? That's easy. You go to one of the clinics, you sign in, you say you'd like to be a part of the Project 2021, and the doctors in the participating clinics will explain to you what you're eligible for. And there's more information on the Project 2021 website that I think Meg's put up earlier. Why start a CBD-only CBMP before a mixed THC product? Evan or Charlotte want to go with that one?
Yeah, I think Mark asked this question in the chat as well in relation to maybe that case that I presented. So the short answer here is one necessarily wouldn't. So there's a big answer here that can be more detailed and nuanced. But what I would say is this. Again, cannabis is more than one medicine. There's multiple different medicines in the one plant. When you're treating or doing something in medicine, it's always good to try to manipulate one variable. So if I have a product that it's just CBD with minimal of something else, I might want to try that first in order to kind of maximize just the CBD without having to worry about the effects of the other medications, or at least to minimize the effects of the other products. So in some cases, I might want to do that. In other cases, I might not. A lot of that now is my own personal experience, my own understanding, where it again gets more nuanced because there's no evidence to guide in this case. If anything, though, from kind of a new place like the UK that's going forward with cannabis, this purified CBD products are really probably what's going to be available, which is available, like Epidiolex. And so it might be that, that's where people start to get comfortable with it in their prescribing, and then kind of move into the more the other cannabinoids and whatnot. But again, it depends what you're doing. It depends what your goals are. It depends what your aim is. For that girl that I presented, I did not try her on just CBD. I was using an oil that was a 1 to 25. So there was some THC in that initial case, but it was a small amount relative to the CBD that I initially treated with her.
Yeah, and we shouldn't forget Epidiolex is also, it's 1,000 milligrams of CBD to 3 milligrams of THC. So even Epidiolex has a tiny bit of THC in it, which some people seem to forget.